Welcome to Benefits Redefined, a series of conversations focused on rewriting the employer playbook. If you're an employer today, you're being pulled in a dozen directions at once. Rising healthcare costs, increasingly complex care decisions, growing employee expectations, and constant innovation. Too often, those forces are treated separately. Costs live in one conversation, care in another, culture somewhere else entirely. This podcast exists because those things don't actually operate in silos. I'm Richard Silberstein, and I work with a group of colleagues across the country who spend our time helping employers move beyond transactional benefits and towards strategies that actually work in the real world. Each episode features practitioners who are in the work every day, not theorists, not sales pitches, but people helping employers navigate what's next in employee benefits, healthcare risk, and enterprise strategy. In today's session, we're tackling a question every CFO and HR leader is wrestling with. How do you actually know if your health plan is performing, and what is it costing you when it isn't? I am super excited today for our discussion with Tina Wilt, a chartered Health Rosetta Advisor with nearly 30 years on the employer side of benefits and the architect of a community-owned health plan built from the ground up. Tina has helped employers score their plans, find the leakage, and move from status quo spend to real measure results. Tina, welcome to our podcast today. Great to see you.
Hi, Richard. Thank you for having me. I'm excited to be here.
So, Tina, for those that don't know you, tell them a little bit about who is Tina Wilt and a little background.
Thank you. My name is Tina Wilt. I work with the Alara Group in Mechanicsburg, and my passion has been, over the last probably decade plus, optimizing health plans for employers. So whether it's from a consulting role, architect, analyst, all of those things come into play as I work with employers to understand how to purchase healthcare differently and really step away from the status quo legacy type of approach.
So one of the things I know that as we've gotten to know each other over the years in our advanced health strategy group, I'm really impressed with some of the things that you're doing in central Pennsylvania that are also being done by Health Rosetta advisors around the country. Before we jump into sort of Health Rosetta and the plan optimizer, just tell us a little bit about what is a community-owned health plan and what have you done in central Pennsylvania?
Thank you. So community-owned health plan, it's kind of a nebulous name. You know, people don't really understand what that means, but basically what it is a health plan that simply reinvests any kind of dividends back into its own community, as opposed to sending profits off to either investors or large corporations outside of the area. So really it works to help employers reinvest in their companies, reinvest in their employees, and also the physicians that work within the community-owned health plans are able to kind of keep their monies local.
Great. And I know this wasn't part of our arranged Q&A today, but having been to a meeting last week in central Pennsylvania where you moderated a discussion about direct primary care. I just think that before we jump into some of the other topics, could you just talk about, which I know is a passion of yours and something that you've done a great job with, but what is direct primary care, sort of the Reader's Digest version, and why should people know about it?
So primary care impacts the overall plan performance. And my recommendation has always been to overinvest in primary care and reduce any barriers to care so that folks have access to a physician where they might have a relationship. They can talk beyond transactions. The doctor is not, coding a CPT code in order to get paid for by the insurance company. He actually cares about your whole person and your whole care delivery. So DPC is a pillar within an optimized health plan. And it really helps to keep care where it's least costly and where you have a relationship with the provider who is invested in your overall wellness.
And it was great hearing the stories last week of examples of physicians that aren't beholden to the hospital and the health system that can help somebody get a scan or get care at a fraction of what it would normally be. So really loved hearing that last week. Okay, so let's jump into sort of the topic for today and, some of your passion. And talk about first, what is Health Rosetta? Who is Health Rosetta? I know that you and I are looking forward to our meeting in Nashville, and we always come out of there energized. But for those that don't know about it, what can you do to sort of describe that?
So a little story. So about 10 years ago, I was really disheartened with my role as a consultant. And I thought to myself, do I want to continue doing this? How can I actually impact employers in the most positive way? Lo and behold, I found a book by Dave Chase, The CEO's Guide to Optimizing Health Plans, where significant savings can be realized. And I became a charter member. So they started probably 2016, and I was within the first cohort. This really brought back my passion to help employers understand that they do have control. They have control over their health plans, and that they don't have to usurp that over to a large insurance company that doesn't really have their best interests in mind. So Health Rosetta, in a nutshell, is just simply a grassroots effort. Now there's probably over 300 plus advisors across the country who are applying the fixes that exist today for purchasing healthcare in a more responsible way. That's really what it is. So we believe that you build something better alongside of what maybe legacy solutions offer, and then invite folks over to experience a new way forward and, meet folks where they are.
Yep. And I think what's great is it's a community that involves brokers and consultants, but also I'd say vendors and partners, but more importantly, also involves employers who get nominated for Rosie Awards. And it's great to sit next to an employer. I was at your DPC event, and to hear what people are doing with on-site clinics, direct primary care, where they're really bringing better access to healthcare to their employees and their members, lowering employee costs, lowering employer costs, and improving health outcomes. So really exciting. Okay, so one of the things I wanted to have you on today specifically is Health Rosetta has created something called the Plan Grader and Optimizing Your Benefits. And as I have talked to you, it's like more people need to know Tina Wilt, and they need to know what is a plan grader and how to optimize your benefits. So let's start off with how would you describe a plan grader in terms of the Reader's Digest version?
Yeah, it's a great tool. It's just another perspective at looking at your health plan to see if it's properly aligned with the blueprint that Dave Chase espouses. So what it does is it allows a plan to evaluate 8 separate components within their plan against the Health Rosetta principles. And so it consists of 40 questions in the assessment. It takes about 40 minutes, maybe a little bit more, to go through the assessment. And the assessment grades an employer against a universe of plan grade participants. So it would be those who have elected to complete the plan grader. And you would get a score from 0 to 100. The median score obviously being 50. Many plans, when they first do a plan grader, fall on the lower end of that continuum. And as they further optimize, they can move up the continuum. And it's really something that should be done annually to track your progress towards high-performing health plans.
And in our show notes, we're going to have some links and some examples, sort of sneak peeks of some of the information. But talk about, what does somebody get? So let's say they sit down and they go through the questions, and you and your team put together a deliverable. What is that deliverable, and what's that roadmap, and how's that work?
So the output is an opportunity summary. So it takes all of the components in the questions, and it grades them based on optimization. And then what you receive are recommendations on ways to fix them, or how to move in the right direction, low-hanging fruit, then we at Alera distill that down, distill a 40-page opportunity summary down into a digestible deck, if you'll have it, with key takeaways. And so we work in tandem with employers to create a multi-year strategy to say, okay, well, what is of interest to you to tackle in year one? What are some things that really have a relatively light lift to them? Moving on to things like, disrupting PPOs and things like that on the other end of the continuum. But there are many things that can be done in the first year, which don't really have impact on employees. And really, it's just tightening up the infrastructure.
And what's interesting is a lot of people, and we talk about this with our advanced healthcare strategy group, a lot of people feel that if I'm a smaller employer, let's say 50, 75, 100, 150, right, I'm too small. The worst is if they go self-funded without having some guardrails in place. So talk about what size employer does this apply to? From how small to how big?
Most often, the levers that are indicated within the plan grader for consideration by a plan sponsor would require that they have some form of self-funding, that they have line of sight into their claims, utilization. So that would predicate about 50 employees on the plan would be about the lowest. Now, of course, if we can do self-funding below that, it does allow line of sight and transparency into all of the things that ultimately would need to be graded. And then it's really, the sky's the limit on the top end. As long as you're using a self-funded chassis, we have flexibility to deploy a lot of the recommendations from the plan grader.
And I think a lot of people might have looked at self-funding before if they're on the smaller side and said, it doesn't make sense, or what happens if I have a bad year? But I think for people to know that the nice thing about Health Rosetta, the nice thing about Alera Group is that they've packaged some captives for those smaller employers that have a lot of these point solutions. We see clients where some employees want a big drug, $125,000 drug, and they're like, we can't go self-funding. And if they went self-funded, they might get that drug for $35,000. So really important for people to know about that. So my next question I have for you is, what's the single question on the plan grader that often surprises a CFO or HR leader when they hear their own answer? Like, as you get into it, what are some of the things that you unpack with them where they're like,
Yeah, so I thought about that, and really the control piece of it comes to mind. So healthcare is local. So employers, when you kind of reframe that, they're thinking, oh my goodness, my providers are also local. So why don't I just link arms and posture myself as a payer doing a direct contract with a provider in my own community? Oftentimes, those providers are very receptive to working with employers who are motivated to pay quickly and remove all financial barriers for employees. So that was one of the things that became that aha moment for a lot of the anchors within the COHP is like, hey, this community means a lot. And we actually have aligned incentives with physicians and certain hospital systems to really raise the bar and do things differently, get the payer closer to the actual provider of care, and really extract all of the muck in the middle and do business. So that was the aha moment, is that you can really leverage relationships within your own community to optimize health plans and to really bring about some positive changes for employees when it comes to relational care.
Yeah, and I think one of the things we talk about is that a lot of people think that all of this is really for, large companies, large employers. But we do see, especially in certain communities, people having direct contracting with certain quality physicians, physician groups. For those that might not be familiar, what is direct contracting?
So direct contracting just simply allows the payer, who would be in a self-funded plan, the employer, to pay out of their general assets directly to a physician, whereas the physician can bypass all of the heavy lift, if you'll have it, working with an insurance company, such as waiting for payment, maybe very complex and difficult pre-certification requirements, things like that. So you can actually create a direct contract with a provider that allows them to practice care in a way that they always dreamed of. So when you approach certain provider groups, whether it's a large independent orthopedic practice, primary care practice, imaging, things like that, your incentives are automatically aligned because there is so much waste and bloat within the system that if you give them a lifeline with a direct contract, fair terms, no one's looking for, a significant measure below, what someone needs to operate. What we're looking for are fair terms, not egregious terms, which oftentimes come with a lot of PPO contracts. So we know that if you base your reimbursement on a fair, measurable amount, such as a percentage of Medicare, it demystifies the discount off of charges, and everyone can talk the same language. So it's very effective. It's very effective to begin talking that way with physicians.
And what people don't realize is because they go to the physicians in the network, right, is that I go up the highway and I take a left to go to this medical facility and I take a right to go to this medical facility. One might charge $1,200 for an MRI and one might charge $3,000. And so it isn't that the $1,200 one is lower cost and worse. It's in some cases it's just as good or better quality of care. And so you're sort of directing people to that place. It's interesting. We have a nonprofit association in Delaware that put together their own health plan for their 500 members. And many of the members are in the healthcare space. So Alaire was able, with our direct contracting expertise, to take 4 or 5 of those members who say, hey, can I work directly with the other nonprofits where they come here and I'll give them a financial benefit from that. So just for people listening in, it's not just for your Walmarts and your Home Depots. It's a lot of stuff is happening, as Dave Chase and as Health Rosetta and Tina said, in the community from that standpoint. So Tina, here's my question. So I'm a CFO and I'm sort of, we have skeptical CFOs, right? And we have CFOs that are kind of like, really, I think I have this under control. We shop our benefits every year. I have a good relation with my broker consultant. And then you do a score of them and they're 50. Like if I'm a CFO, what's the difference between a 50 score, a 70 score, or an 80 score in terms of financial, in terms of impact for their employees?
Yeah, so as I said, when you first do a plan grader and maybe you're just dipping your toe in, you're gonna score in the 20s. You're gonna be a little bit lower on that continuum. As you implement aligned strategies, you can move towards the median. And then once you really start to optimize, you're going to be getting into the 60s, the 70s, the 80s. I honestly have not met a plan that has scored 100. So I think that that's a little aggressive, but even some of my more optimized plans using reference-based pricing, direct primary care, were squarely in the 70s. So the score itself is not as important as the momentum and the change in the multi-year strategy to be able to move to a better reality. And depending on what levers you choose, now what what most plans tend to do is really attack their pharmacy benefits first. And that can have a significant impact on their overall spend. So if that's maybe where you want to start, you can see a delta in your plan score pretty significant between maybe where you entered at 20 and maybe the next grading period the following year after you've implemented, moving up to the 20s. Up to the 50s. So it really depends on, you must meet your culture and your organizational objectives where they are. And then you just simply systematically move them over time in terms of what makes sense to you. We have seen savings of up to 40% on claims between a legacy plan and a fully optimized plan, if that's any indication.
Yeah. Well, it's interesting. We just looked at a situation with a large employer that our clinical team looked at, and there were 4 people that site of service would save them $4 million. 3 were dialysis, right? Mm-hmm. So, and we're not talking about going to lower quality care, but excellent care, just taking the left exit, going to the left on the highway versus the right. And then one was having infusion not in the hospital, but in a home setting, which is, even better in some cases for the patient. So those are things that most smaller employers feel like, I can't do that, but there is a playbook for that, and there are vendors, and that's where this Health Rosetta and the Alera community have sort of vetted them for best practices. My question for you is most employers that go through this, let's say they go from fully insured to self-funded, or they're self-funded, it feels as though there's a crawl, walk, run. I know I get a hard time for some of those analogies, but there's a crawl, walk, run where they save maybe 10 to 15%, and there is savings, but the other thing is healthcare trend is 10% plus now. And so you also see that the trend is lowered. So are they sort of saving money initially and then flattening the trend over the next 3 to 5 years? What do you see with a lot of the employers that are active on this?
Spot on. That was a great observation. So yeah, you'll see initially a nice savings. And then what you see is a resting trend. And then you may, depending on the levers that you pull or the programs that you deploy, see a negative trend.
And so if somebody wants to figure out what score they have, right? And what is this? What is the process in terms of the time? So let's say there'll be some notes in the show link, and they'll connect with you on LinkedIn, connect with me on LinkedIn. But let's say they follow up with you and they say, hey, I want to learn more. Talk about the process, the timing, and how easy in my mind it is. But in your own words, what would a CFO or a HR leader need to know?
It's very easy. So to the extent that you're interested in learning what your score might be, just reach out to myself or Richard. We can facilitate a virtual assessment. It doesn't require a whole lot of data collection. What you'll need is someone there that's familiar with your benefits when we do the assessment. You'll need to have someone there that's familiar with the finance part and the benefit structure. So it might be someone from finance, it might be someone from HR to sit in. Then we'll walk you through the questions and really help you understand what are they asking? What is it that the assessment is trying to fetter out, if you'll have it? So, like I said, 45 minutes, and then we input that information into the Health Rosetta system, and we get an opportunity score or an opportunity summary right away. And then we distill that down. So I would say that it's probably in total a 2-week process. It's not a heavy lift. You don't have to send us a whole bunch of information about your plan. You keep that in your space. You just share with us going through the assessment.
And not to put you on the spot and feel like Jeopardy for Health Rosetta, but David Chase talks about local. Do you want to share what local is, or do you need a little?
Sure. No, I have it right here. I have it. So the acronym that we use in the plan grader, and I talk about it often, I talk about healthcare being local because I believe in reinvesting back into our community and making it stronger as opposed to siphoning money out. So local is the first thing you would want to do is learn to be liberated from the status quo. So I coined the phrase, you can't unsee what you've seen. I mean, once you see something and some of the egregious practices that exist, and they're very self-serving to the provider, to the, providers and insurance companies, it just kind of turns the light on. So, but it's a continuum. You have to continually educate yourself about some of the things, some of the forces that are perhaps working against you. And then optimize your health plan infrastructure would be O. And that's really looking at the contracts and the foundations within your plan. Contracts are a place where a lot of hidden misaligned incentives and disincentives for the employer exist. So I would do a deep dive into your plan documents and really identify where there is a conflict and work to get those exercised out of your plan documents. Carve out your pharmacy benefit manager. So that would be C. So, the old adage, carve in or carve out. So carve out your PBM. Look at independent PBMs. Look at how rebates can be passed through. If it's not rebates, how do you leverage manufacturers' dollars? How do you source differently? There's just a number of things that you can do to really drive down the cost of drugs. Add value-based primary care. That would be A. So like I said, it's a core tenet within all optimized plans to overinvest in primary care because that's where you're going to get the biggest bang for your buck, not only downstream, but also keeping people healthy on the preventive whole health side of things. And then L would be maybe the last thing that you want to do, which is leave behind value extracting PPO networks. And that's really optimizing the direct contracting, narrow networks, cash pricing, things like that really demystify the whole, charges versus discounts thing. So that is the acronym for local. And that's just kind of something you want to, your mantra that you want to kind of, that's something that I really need to be mindful of as I go through this process.
Right. And I think what's cool is that we see very large companies that are doing really cool things, on-site clinics that are doing innovative things that are, public companies, big companies. And what's nice is Health Rosetta, Alera, Advanced Health Strategies, that's how you can bring that down to a smaller employer. Mm-hmm. And then what's nice is these smaller employers, what I loved is when we went to dinner at Health Rosetta and we had a table of Alera clients there where they're sharing stories. And then at your DPC event, I sat at a table with 4 or 5 employers that were just sharing some unique things they're doing and sort of comparing notes. So I think it's important that people know that they can do it, that they're not alone, and there's this group of really cool employers out there doing really unique things for their employees.
It's a community. It's a community for sure. It takes a village. It takes a village to make things happen. And, you're going up against a $4 trillion industry. So it's not for the faint of heart. And where I see things working is persistency and resolution. So you have to be resolute. You have to know that what you're doing is grounded in best practices and, it's morally and ethically the right thing to do. And really, you need to manage your plans like you would any other fiscal type of expense within your company and not do like the 90-day blitz before renewal. With the Health Rosetta plan, you strategically work through the year to optimize the time just before renewal to know what you're doing, why you're doing it, and have an architect or an advisor with your best interest in mind kind of, in the background there for you.
Yeah. And we had other episodes where you talked about pharmacy, fiduciary, all those other things. And we look forward to having you back for several more. I have a list of like 40 questions, but I'm not going to have a 4-hour podcast, but we'll have some other time together with you. And I really appreciate you being here today.
Thank you.
Good to see you.
Good to see you.